Hello, I'm Dr Louise Newson. I'm a GP and menopause specialist, and I'm also the founder of the Newson Health Menopause and Wellbeing Centre here in Stratford-upon-Avon. I'm also the founder of the free Balance app. Each week on my podcast, join me and my special guests where we discuss all things perimenopause and menopause. We talk about the latest research, bust myths on menopause symptoms and treatments, and often share moving and always inspirational personal stories. This podcast is brought to you by the Newson Health Group, which has clinics across the UK dedicated to providing individualised perimenopause and menopause care for all women. So today on the podcast, I have someone called Christiane who reached out to me a little while ago from the other side of the world to me. She's in Australia, and she told me her story, which really resonated because it's similar to many, many stories that I hear all the time, actually. A lot of it is about women not being listened to, but also women who have more than one diagnosis that often aren't just put into one sort of diagnostic box and given one treatment and off you go. When it's more complicated, sometimes it can unsettle and unnerve doctors, and sometimes it can be very difficult to be heard to get the right treatment. So Christiane's very kindly agreed to share her story so it can empower others and make changes to other people's lives going forward. So hopefully they don't suffer as long as you have before you finally feel better. So welcome from Melbourne.
Thank you, Louise, and thank you for all the amazing work you've done for decades, long before, that menopause was in the zeitgeist or being spoken about.
Thank you. So you, like many women actually, have endometriosis, which I've spoken about on the podcast before, and I'm sure I'll speak again. And some statistics say that it can take a decade for people to have a diagnosis, and many consultations before the diagnosis is made. And that's sometimes because it can be difficult to diagnose, but it's more commonly because people aren't understanding endometriosis and the effect that it has on people. So do you mind just sharing a bit about your story?
Not at all. And I just want to point out at the outset that I definitely don't want to make it just about me. I know there are so many, countless women in my position. And this is the story of so many, which is really sad and actually quite tragic. So yes, you're right. It took about a decade for me to be diagnosed. And by the time I was, and you normalised the pain as well. So I just thought it was me, and that, my other people responded to simple painkillers and I mustn't be, I must be in some way defective. That was really terrible. And by the time it was diagnosed, I ended up losing, having an ovary removed as well as appendix, and also a punctured bladder in that surgery as well, which also I wasn't believed about until Mum took me back 3 times to emergency. So, it is a story of as old as time, I think, and that I probably had around 10 laparoscopies after that, and every single time the sense of not being believed. I also went to a few different specialists, some of them incredibly, at the top of their field, and still being told this is chronic pain, or, this is normal. And I like to think I have a fairly high pain threshold. So, but as I said, you just normalise the pain, the moods. However, luckily I was very fortunate to come across Professor Jayashri Kulkarni, who, as you know, you've spoken with, and her very important work around women's mental health and hormones. And I was diagnosed with PMDD in my mid-20s, and that was very helpful. But still, despite, the ongoing endometriosis and all sorts of medications, tried HRT before my hysterectomy, but ultimately ended up doing IVF on my own, partly for given the history of or the surgery. I have no doubt that's why I was single, just feeling, and I still am single, feeling quite, and I don't mind saying that. I mean, I've basically been single for 2 decades. I think largely given that sense of brokenness that you feel having, that physical as well as psychological disease, I guess. Yeah.
Yeah, no. So PMDD is premenstrual dysphoric disorder, and it's a more severe form of PMS. And PMS, premenstrual syndrome, probably affects about 90% of women. There's very few women who don't have any changes before their periods. And before the periods, as you know, is when hormone levels are at their lowest. And so a lot of people I see and speak to who have endometriosis also do have some PMDD as well. And the more I think and treat and talk to women with endometriosis, the more I think, or I'm interested to know how much of a hormonal disorder it is and how much it's related to low progesterone and possibly low testosterone as well, because those hormones are very anti-inflammatory. And traditionally, when we talk about hormones, it's always about estrogen being the building block. Estrogen's the important bit. Estrogen, estrogen, estrogen.
Yes.
But actually, these 3 hormones are independent. They're as different as, other hormones in our body. They're always lumped as sex hormones, but they don't define us, our sex or our gender, because men have the same hormones too. And a lot of people I speak to do respond very well to testosterone and progesterone, and maybe less estrogen or no estrogen, depending on the individual situation. And it can take a long time, as you say, to diagnose endometriosis. But it also, even when it's diagnosed, the treatment really varies between women. And, the surgeons will say it's all about surgery. Other people, if you go to a pain clinic, they'll say it's all about pain control. If you go to a psychiatrist, other than Professor Kulkarni, they'll say, oh, it's all in your head.
Yes.
You can just, put up with it. And then other people say, well, just take out your womb and your ovaries. If you take out the ovaries, you'll have no hormones and therefore you'll be fine. But actually, that's not always the right thing either, is it?
No, it's not that simple. And the reason I ended up fighting so hard to have a hysterectomy was literally listening to your podcast with Dr. Hannah Short, the GP, I looked up this morning in 2022 it was. And it just gave me, her story was very similar to mine. It was just untenable to live with the PMDD the way it was for her. And she fought to have a hysterectomy, as I did. Unfortunately, even though my specialist was excellent and very senior, he still, he had reservations for the right reasons, but just I guess the lack of knowledge doesn't help. But I remember him saying, well, if I do a hysterectomy, it will shorten your lifespan by 5 years.
Gosh.
And I sort of said, oh, what? And he said, well, given the cardiovascular risks. And then he proceeded to calculate how old my son would be when I died.
Oh, my goodness.
This is true. And so I sat there and took all that in, and it was only afterwards, speaking to someone, that I thought, gee, that was a terrible thing to say to someone, because it left me in an impossible position of my quality of life being so poor and big surgery that is, holds a lot of grief as well. So in the end, he agreed based on, the psychiatric support, letter of support, but we retained one ovary, and of course, because the ovary is producing the hormone, that the PMDD continued. And so I fought again a year later to have that ovary removed, and I'm now an HRT, and the prometrium, the bioidentical progesterone. Yeah, so it's been a lot. And that was 2 years after having my son. I had the hysterectomy after being told that pregnancy cures endometriosis, which is another old wives' tale, because it clearly doesn't. And, that's where you almost gaslight yourself, just thinking, is this me imagining the pain and being told by doctors it's not there? And it was. So, yeah, you just got to trust your own body, I guess, but that's impossible in the face of really experts who I'm sure are well-meaning, but it takes a toll.
course it does. And one of the first things I learned as a medical student is listen to your patients. The patient will always tell you, but you have to ask the right questions. But also, patients don't come to the clinic, or they've never come to see me as a doctor making things up. There's no psychological advantage of having symptoms, and sometimes it can be really difficult. And one of the things I learned actually in general practice, in hospital, you've always got other people you can ask, you've got tests, you've got investigations really on your fingertips that you can always try and explore more and more. Whereas in general practice, when you've got 10 minutes, you can't order scans left, right and centre. You don't always know. But actually dealing with uncertainty is something that's really, really important as a doctor, and sharing that uncertainty. And I'm a very honest person. And so I'm always very honest with my patients. And actually my trainer a long time ago, John Sanders, taught me that it's okay to tell people that you don't know what's going on. And the first time I did it, I thought, oh gosh, they're going to think I'm a really bad doctor. But actually, it's not that. It's, sometimes you don't know, or you think, well, there's maybe 2 or 3 different things going on. And so I'll often say to patients, look, there is a lot going on. I think you might have X, you might have Y, we could do A, we could do B. Let's just do it in stages. But I might not be able to help everything, but I'm certainly going to work with you, and let's explore all possibilities. And that way.
But that would be a relief. That would be a relief for patients.
And I know, having been a patient quite a few times, you just want to feel validated, and you want to feel that someone understands you, and also that you're not making it up. There's nothing worse than being told it's all in your head.
Yes.
Or someone trying to make a different diagnosis to suit their agenda. I know a few years ago now, my daughter had sepsis in her sacroiliac joint, and she presented with awful pain in her hip. And I had to take her to casualty at 3 a.m. because she was in so much pain. Well, if I couldn't take her, I couldn't mobilise her. She had an ambulance. But we got there and the x-ray was normal. And the consultant said to us, oh, I think she just needs some physiotherapy. And I looked at her, and she'd started vomiting at this time and was in so much pain. And I looked at the consultant and said, what makes you think, when she's had no injury, that physiotherapy is going to help this 12-year-old girl who's clearly quite unwell? Could you not even take a blood test? And then she went, okay, we'll keep her in until the morning ward round. But it was that whole, and we sometimes talk about this as a family, because if I wasn't medical, I would have just gone, oh, okay, then I'll take her home. And I know she probably would have died because she was so poorly in the days after. But that's quite an extreme case. But actually, it would have been okay for that doctor to say, gosh, I don't really know what's going on. Maybe some physio would help, but she doesn't look very well, and she's got worse in the hour that she's here. Let's just keep an eye on things, and I'll ask my colleagues in the morning. That would have been fine. So it's the way that we talk. And the more I look at the gender inequality, there's so much more that women are misunderstood. It's the women that have system disorders, women who are complex, women who have personality disorders, women who, have all these medications, women. But actually, what's different about us is that our hormones are often changing all the time. And we've never really been used in proper experiments or, clinical trials, because our hormones exclude us because they're too complicated. And that makes it really hard. And then with some conditions, including endometriosis, synthetic hormones have been given, which aren't the same as natural hormones. And, some people say, well, estrogen will flare endo, which it often can do. But what about the other hormones? What else are we doing? And it's that individualisation of care that I think has been missing for so long. And women are just given layers and layers of diagnoses, often inappropriate medication. And then what do you do? Who do you go and see if no one's really addressing the problem properly?
I know. And that's where people like me end up. I mean, I'm a researcher, but I'm not a doctor, though I feel at times I've had to educate GPs. And like Professor Kulkarni has mentioned many times, that women like me, thankfully I haven't, which is, I'm incredibly grateful to her, but being diagnosed with bipolar disorder, and put on antipsychotics when it's a hormonal condition. And, I definitely, that hasn't happened to me, but the shame of not being believed has a severe mental health impact, and I think is traumatic for many of us. I'm sort of coming to terms with it now that I'm looking back. I'm almost 44, and as I was saying to you actually earlier, I'm starting to feel angry. I'm not an angry person, but I thought we'd just got through another HRT shortage, and as of yesterday, I've just spent hours on the phone again trying to source estrogen patches. I'm on quite a high dose twice a week. And the mental load of that for women is enormous. And yes, the good thing is women are speaking about it. And as you've said, in Australia, there are a number of journalists who are going through perimenopause and menopause in real time. So like Mamma Mia, the media company by Mia Friedman's doing a lot of work on that, and obviously Professor Kulkarni, but there isn't, what do you do? You've got nowhere to go if there's no supply. And it really is a human rights issue. I'm not sure if it's going too far to say that.
I don't think it is, actually. We've had shortages over here, and actually in my paperback book, one of our pharmacists, Hayley, has written about what to do with a shortage. And actually at the minute in the UK there isn't a shortage, but I've just changed my patches today, and I realise I don't have any more, and I'm going away at the weekend, and I will be able to get a prescription. But it's still and it's not, it's just the fact that I know that I will get migraines without my patches. I know I won't be able to think and function. So it's not like a lot of people think it's just a lifestyle drug. It's just a nice to have rather than the need to have medication. And this is where hormones, I think, are just not taken seriously enough. The work that Professor Kulkarni does is so important, looking at the mental health aspect of the menopause and perimenopause and PMDD, obviously, and PMS. And we've just written a paper together because we have to address the importance of mental health. We can't just be layering on sticking plaster. And a couple of days ago, I did a event for a NHS Mental Health Trust, and it was an interesting audience because there were just women from the public there. There were consultant psychiatrists there, and there were some mental health workers. And afterwards, I spoke to some of the people, and one of them, the consultant psychiatrist, specialises in psychosis, and she was asking me about the role of hormones. And she said, I've never really thought about it, but actually I wouldn't have no idea how to prescribe HRT, and I'm really scared of prescribing HRT. And I'm just like, well, you have to learn. It's really important because there's really good evidence, and actually they are safer than a lot of antipsychotic medication. And antipsychotic medication will increase prolactin, which they always test prolactin levels, and higher prolactin will reduce FSH, so it will give people a chemical menopause. So if they're not menopausal before, they will be with the drugs that you're prescribing. And so she was like, I need to listen, I need to learn, I need to do your education program. So she went off, wanting to learn more, which is wonderful. And then there was another lady who's a patient, and she said, I've been diagnosed as bipolar. I know I'm not. They talk about psychosis, but I know it's related to my hormones. It's taken years to be listened to and believed. How do I get my voice heard? And that's really difficult, isn't it?
It is. And people, I've read in some of Professor Kulkarni's work, there's suicidal outcomes in these situations. I luckily wasn't, but it's taken years and years, and the stress of trying to, I've got my son screaming in the background, trying to, on the phone to the pharmacy, who's basically saying, oh, no, we've got none. And of course, everyone will be different in terms of what dose they're on, but I'm on quite a high dose because I'm young. And it seems to be working. I've never had a hot flash, and that's the other thing. It is so individual, isn't it? The stereotypes around hot flashes, what happens to me will be completely different from what happens to another friend. But so far it has been really positive. And I don't have endometriosis either, and I don't have pelvic pain. But I was sent off to pelvic physios by surgeons, just assuming it was, which is, a very good resource, but in my situation was inappropriate. And, decades ago, it was quite invasive, not around consent, and quite traumatizing. And that was all to prove that actually, no, there was no issue with my pelvic floor. It was endo. So that's really devastating. Similarly, in pregnancy, I was so lucky. After 7 rounds of IVF on my own, had my son, who's now 5, and I persisted after having him. And that was, a surprise, given I'd been told that pregnancy would cure it. So, you're just managing at all life stages, trying to, as a younger woman, around sexuality, as a mother, still trying to manage the pain, and now I'm in menopause, and that's actually better. And as Professor Kulkarni would say, and we weighed up the options, the PMDD and the pain of endometriosis were worse than the prospect of menopause. So, and that has been the right choice for me.
Yeah, which is so important, being so involved with decision making, then knowing that the treatment that you're having is right for you. But I mean, having all those rounds of IVF by yourself, just bringing up a child by yourself, it's not easy, is it?
No, it's not. And it's, in some ways, the baby, everyone warns you out, you're not going to sleep again and everything. And I think for the first few years, and definitely while I was breastfeeding, my hormones were great for the first time in my life, which I'm sure you know about. And then I fell off when I had to stop because of surgery. That's when the endo and those problems started occurring. But yeah, he's amazing. And I used an anonymous donor. Unfortunately, there's an enormous shortage of donors now in Australia. I'm not sure about the UK, but given in Victoria, at least where I am, the legislation changed a couple of years ago, which meant that donors can be identified when the child is 18. So that understandably really deterred a lot of men from donating. And I mean, I think when I was looking at the database, like you're shopping for something that's not a donor, there are about 8 donors at that point.
Gosh.
And I am very efficient and sort of a bit of I don't know, I don't know if it was my background in research, but I chose one that was perfect for me, and I'm incredibly grateful. And one nice thing I don't think I mentioned to you was we've met 2 of his donor siblings who are twins at his age, so the same donor and this wonderful mum, and they live about 40 minutes away. And so that's a really beautiful thing. But yeah, complex and emotional, and I think bringing up a child when I've still got residual health issues, given the aforementioned history, is tough. I don't want him to look back and think of me as, my mum is struggling or disabled, but hopefully, I mean, all he knows is he's got a mum and a nana and a donor, and he's happy with that.
And I think just to pick up on you saying about the consultant that you saying that if you have a hysterectomy, it will shorten your life by 5 years. Firstly, no doctor has a crystal ball. We have no idea what we're going to die from, and no idea. What we do know from the evidence is that when women have a surgical menopause or a menopause at an earlier age, the longer they are without the hormones, the greater the incidence of diseases and an earlier death as well. But, and this is a real but, if people have replacement hormones, then that reverses, because all you're doing is not replacing, you're just giving back what your body would be producing. And actually, a lot of people who have an earlier menopause, if they've had some hormonal insufficiency, actually you're giving appropriate hormone doses back, probably their prognosis will be even better, because a lot of women are spluttering a bit with their hormones, not producing as much. So you're giving back a really good physiological dose, and our hormones are very active biologically. So the research hasn't been done because so little has been done on proper body identical hormones. But
I tried to find it.
No, but it makes complete physiological sense, actually.
Yes.
And we know that older women who take HRT have a lower risk of diseases, a lower risk of an earlier death. You know, they usually live longer and healthier, because it's actually not the age we die anyway. It's our journey to that age. You know, we could all live longer, but be more unhealthy, and none of us want that. And so I think for anybody to try and talk about life expectancy to patients, unless they're missing, you know, they know something I don't, it's impossible to say. But what
it was cruel, and until I spoke to Jayashree, and who said exactly as you did, and the benefits of HRT in terms of cardiovascular health are undeniable in itself. It's not for the specialist. I remember speaking to a psychologist and her saying, well, it's not for him to decide whether your quality of life is worth, even if it is 5 years. And in the end, the whole 5 years thing, as you say, is very theoretical. Yeah, but it was a terrible, the guilt around that was, I'd already had my child. You don't, and which mother or what sort of parent would ever accept dying 5 years younger? And as you say, my hormones are actually more stable now than they have been since I was 12. So there you go, if anyone's wondering.
So good news at the end of a very long, over 30-year-old, you know, journey, that it's worth persevering, because people can get there in the end. And even when you feel it's insurmountable or impossible to feel better, often finding the right clinician, finding the right treatment for you as an individual can work. So I'm very grateful for your time, but also your honesty as well, because I'm sure your story will resonate with lots of people and hopefully give them that fire in their belly to really be listened to. So before we finish, there's always going to be 3 take-home tips at the end of the podcast. So 3 things that you feel, if people have listened and felt gaslit really, or cheated on with information or an incorrect diagnosis, or something doesn't feel right from the clinician that they've been seeing, what 3 things would you recommend women to do?
So I think the first one I thought of was just educate yourself or listen to women's stories. I don't mean on TikTok. I'm not on TikTok, but I mean listening to evidence-based podcasts like yours and your website and information. And we need more of that in Australia, but luckily we're now, all connected, which is great. And I think talk to your daughters and nieces, and, I get on my soapbox if I hear, young women in pain. And I think it's sharing stories like women always have is really powerful. And that's how I came to have the strength. As I said, listening to your podcast and hearing Dr. Hannah, that was incredibly powerful. And I also think speaking to men, I had coffee with a lovely man in his early 40s last week and mentioned your podcast, and I didn't say your name because I just was a bit the stigma, I think, of mentioning menopause, even me. And he said, "Oh, is it Dr. Louise Newson?" And I said, "Yes." He said, "Oh, I heard her on a podcast," and I forwarded it to my mum and my sister.
Wonderful.
So there you go. So I think just talking. And the second thing was push. I know it's easier said than done, but pushing back against that medical gaslighting. And because the impact, as I've tried to describe, is, the impact on the trajectory of women's lives is so pervasive. Don't let the shame of being not believed stop you from believing in yourself, is what I'm trying to say.
That's really important.
And and the third thing was, which is an unusual thing to say, but you're not broken. And I am trying to take my own advice, but it's the system and the structures that are often broken. And I've come out of this, and it's, as I said, now with hindsight, looking back, doing a lot of work around why I feel like that, and the processes of being misdiagnosed, of not being heard, of the shame, of a lot of shame around women's health anyway. The trauma associated with IVF even can leave you feeling, for men and for women, incredibly broken. And add to that trauma, which I don't mind saying, which I hadn't connected, a sexual assault in my early 20s. Add that to the mix of the physical and emotional impact of the other, and I don't use the word trauma lightly, of the trauma of gaslighting and medical misogyny. I think, just retain that sense of self. And I'm sure many people do feel broken. I'm sure there are many millions of women, or thousands, like me. And just remember it's the systems and the structures. It's not you.
I think that's such a powerful way to end. And thank you so much for sharing so many really intimate things actually about yourself, because people will be able to just think in a different way. And I think just not internalizing it and blaming yourself for everything is really crucially important in everything that we do, actually, because as women, we often take so much. And I think to know that actually it's not your fault the way you feel, and that there are people that can help you, but it's fine to get a second, third, fourth opinion. That's absolutely fine as well. So I'm very grateful for your time today, and I just hope this is going to help lots of people. So thank you again.
No, I'm very grateful, and best of luck to everyone.
You can find out more about Newson Health Group by visiting www.newsonhealth.co.uk. And you can download the free Balance app on the App Store or Google Play.